and we're going to be learning about does your how does your body regulate the medication, and how do chronic diseases affect the state of how do the chronic diseases affect the state of the medication. So pharmacology happens to be an applied science. It's not a basic science. So we have two different types of sciences. So science is divided into basic science, and it is divided into applied science. So it doesn't matter what kind of science we're dealing with. There is physical sciences. Physical sciences is where we study the non-living things. An example of that would be physics and crude chemistry, astronomy, geography. So an example of that would be physical science. Physical science is an example of that would be astronomy, archaeology, fossil fuel, physics, geography. When you study the non-living things, then there are life sciences. And life sciences, these are the sciences where we study the living things. An example of that would be the biology and studying the organisms and the metabolism and studying all the biochemical reactions that sustain life. And we have also social sciences. And social sciences, these are the sciences that are responsible for the behavior. So the behavior, you study what are the incentives, what are the rewards. And good morning.
This is LP Pharmacology?
Yeah, pharmacology.
I thought Zachariah was going to be the teacher, no?
No,
You?
no, yeah.
Alright.
So we have behavioral sciences, and these are the sciences where we study how does the reward, the incentive, how does the penalty and punishment influence the behavior of humans and animals also. But in the end of the day, when it comes to science, all of these sciences, whether behavioral science or whether life science or whether physical science, all of these sciences, they could be divided into basic science versus applied science. So we have basic physical sciences, applied physical sciences. We have basic life sciences, and we have applied life sciences. We have applied life sciences, and we have basic life sciences. We have applied behavioral sciences, and we have basic behavioral sciences. And we have hybrid sciences where we mix up. So we have hybrid sciences. What's a hybrid science? A hybrid science is when you mix up two. So you have biochemistry or biophysics. You have life with behavior. You have physical with life. So you have biophysics, and you have biochemistry. That's a hybrid science. Nonetheless, as long as it's a science, we said that it's always divided into two classifications. What are the two classifications?
Basic and applied.
Excellent. We have basic science, so we have basic biophysics, basic biochemistry, and we have applied biophysics and applied biochemistry, applied hybrid sciences and basic hybrid sciences. So what's the difference between a basic science and what's the difference between applied science? So now we are narrowing down. We are getting closer to understanding where exactly does the pharmacology fall. So Basic science is the science that is taught and learned for the objective of learning. So we get more information. We go deeper. So we learn for learning. We accrue more information. We go in depth. So when it comes to basic science is concerned with the objective of foundation and fundamentals and in-depth knowledge and learning more. So you expand your learning. So that is basic science. Applied science is when you apply what you learn. Applied science is not about learning foundations and fundamentals and the in-depth knowledge and expanding the learning, but it is rather to apply what you have learned. It's about applying the foundations and the fundamentals and the in-depth knowledge into solving real world problems. So that is where inventions happen. Inventions do not ever come from basic science. They do rely on basic science. If we never had in-depth knowledge, if we never had foundational knowledge, never had fundamental knowledge, we will never have technology. But applied science is learning how to apply that knowledge. So you guys as nurses, you're going to be learning to apply in your profession this knowledge. How to install a catheter, how to perform an injection. Now you're applying what you learn. The engineer is applying what they learned to make an invention, to create an engine, a machine. So both of them are interdependent, but you're looking for us. Good morning. You sit over here. So when we are doing applied science, we are applying the knowledge that we have learned. So pharmacology is both, two in one. It depends on how you approach it. I approach pharmacology from the standpoint of basic science. I'm not going to be installing anything, applying it. I'm going to be searching for more knowledge so I can give you the information from different angles so you can have the foundation that you need so that on the next step in your profession, in your life calling and purpose, you go and perform your nursing duties. But we gotta look at pharmacology from both standpoints. From basic foundational knowledge, you have to learn how do these medications affect the living system? How do the medications affect the pathology? And you know, when we talk about medications, we are always in pharmacology concerned with poisoning. We are always concerned and we are so worried about poisoning. And there was a philosopher from back in the day. This philosopher, this was thousands of years ago, came up with a definition for what is a poison and what is a toxin. And interestingly enough, it's still true even though it's thousands of years later. And his name was Paracelsus. He was a Greek philosopher. He said the difference between a poison and a remedy is the dosage. So if you have too little of something or too much of something, it becomes poison. So now if you look at water, who would have ever thought that water could be poison? If you drink too much water, ask the marathon runner who was running the marathon, and when they got to the finish line, drinking all the water until they had shock. They had hypervolemia. So they drank too much water, and that affected the blood pH, affected the osmolarity. So now we're no longer at U osmolarity. We're no longer at euvolemia. We went to hypervolemia, hypoosmolarity. We're no longer at eutension. We're now going to have hypertension, increased contractility, increased cardiac output. All of that was caused because the dosage was too much. So the medication is going to become a poison if you do not pay attention to the dosage, if you do not pay attention to who you're giving it to. Am I going to give the same medication dosage to a baby, pediatrics, than to a male versus female, then versus the geriatrics, the really old? Are they going to take the same antibiotics dose? That's going to be a poison. So we always take into account what system are we administering this medication into. We're going to be looking at the dosage. We're going to be looking at how the pre-existing chronic diseases affect this medication that we are so concerned about. So, and we're going to be looking at pharmacology based on system-wise pharmacology. So we're going to begin with endocrine system medications, then we're going to head into we're going to begin with musculoskeletal system medications, followed by nervous system medications. And the first medications we are going to be doing are the dermatological medications for the integument and the skin, followed by the nervous system medications. Then we're going to go into the endocrine system, then the cardiovascular system. So we're going to go in order because all of these systems are based on each other. We're going to be also concerned with pharmacodynamics and pharmacokinetics. How does the medication affect the body, and how does the body affect the medication? We're also going to be concerned with pharmacological metabolism. So when this drug enters into the body, how does it get metabolized? What is drug metabolism? Drug metabolism is preparing the medication to go away, to be excreted. If it is not metabolized, it's going to build up in your body. The toxic medication is going to be building up on your bones. The toxic medication is going to be building up on the fat tissue. It's going to be building up in the liver. So there is a holistic system that is responsible for metabolizing the drugs. Very important system known as the microsomal P450. This is in the liver. So they are known as liver microsomal P453 enzymes. So this is a family of enzymes that are responsible for metabolizing liver microsomal P450 enzymes. These enzymes are a family of enzymes that are responsible for metabolizing drugs and prepping them to be excreted. So now the drug has been administered, the drug has been absorbed into the circulatory system, and then this drug has now exerted its effect, and now it has to be excreted. But it will never be excreted on its own nature. Why is that? What is metabolism? What is the metabolism of the drugs? Drugs always exist in the non-polar form. And you know your bodily fluids are polar, and polar and non-polar do not dissolve. Birds of the same feather flock together. So if I want to dissolve a polar substance, a polar solute, I must have a polar solvent. If I want to dissolve a non-polar solute, I must have a non-polar solvent. So if I want to dissolve fats as a solute, I must have detergent as a solvent. And if I would like to dissolve water, or if I would like to dissolve salt, I don't dissolve water. I use water to solvate and dissolve things. So if I want to dissolve, I use a solution, a water solution, and if I have a solute to be dissolved, then that would be the salt. I have my ions that I need to break down. So if I have sodium chloride that exists like this, sodium chloride, then water is going to come in. You have the big oxygen that is really electronegative attached to 2 hydrogen protons. Then what's going to happen is the sodium is going to acquire a positive charge, and the chloride is going to acquire a negative charge, and the oxygen will say to the sodium, do not bind with the chloride who is negative. I'm even more negative than oxygen. So oxygen will bind with sodium, and chloride who is negative, the hydrogen will say, you used to be bonded with sodium who's positive. I'm way more electropositive than sodium, because oxygen is so electronegative, took away all my electrons. So now chloride is going to be bound to hydrogen. So that's how the solvation happens. Your medications, all the time, they are nonpolar. So if I want to excrete them in the urine, is the urine polar or nonpolar? The urine is polar. A lot of water in the urine. So in the kidney, the nephron is responsible for the reabsorption of water and the excretion of water. But how am I going to dissolve a nonpolar substance in a polar solvating fluid known as the urine? It's not going to happen, because this one is on this side, on the nonpolar, or then the urine is polar. So either I have to convert the urine to be nonpolar, or convert the drug to be polar. Which one is easier? The drug. So that's what these guys do. The microsomal liver P450 enzymes. Tomato, you know them. You can say microsomal liver P450 enzymes, the enzymes of the liver, microsomal P450, as long as you know all of these guys. What they do is they change the chemical structure of medications and toxins and xenobiotics. These xenobiotics, we're going to be learning about them. Xeno means foreigner. You know, they say xenophobia. Xenophobia is when you hate or afraid of the foreigner. You know, they want to build the fence now in Mexico. That's the ultimate xenophobia. You know, so xenophobia is when you're afraid of somebody who is different. So we have now xenobiotics. So this is not xenophobia. This is biotic, means related to the living system. So these are substances in the living system, but they don't come from the living system, they come from outside. Like these toxins. The toxins, they come like asbestos. Asbestos is not living, but now it's in my lungs. So now it's a foreigner in the living system, xenobiotic. Okay? When there is a pollutant in the industrial society, there's human exposure to pollutants in the industrial society. These pollutants now, when they enter through the parenteral route, or when they enter through your enteral route or percutaneous route, they're going to enter your body and they're going to become xenobiotics, foreigners in the living system. So they need to be metabolized, these xenobiotics, quickly, and they need to be excreted out. Excreted in the urine or excreted by the digestive tract. That's also a route for excretion of the toxins. But either or, if I'm going to excrete it in the sweat, if I'm going to excrete a xenobiotic in urine, if I'm going to excrete a xenobiotic in the fecal matter, I have to metabolize it. So the patient with the liver cirrhosis, the alcoholic liver disease, liver failure, they cannot metabolize the medications. So that's why they always get toxicity. And they have a problem taking the medication. The medication does its job, so we're not just concerned with getting the medication in the body. We want to get it out. It does its job and go home. If it stays in there, now it's going to be a disease. After it's going to help us first, then it's going to harm us. So we are so concerned with our liver because they are liver. That is the most important thing. Don't forget who they are and where they come from. They are liver microsomal P450 enzymes. Something wrong with your liver? The alcohol and so the fibrotic liver disease, alcoholic liver disease, then all the medications, they're not going to work. They're going to work, but they're going to build up in your bone and they're going to build up in your fat tissue and causing all of this toxicity. So we're going to be studying the different families of the xenobiotics. How do they exist? How they enter our body? They enter through the skin contact, and after they enter the skin contact, they target the circulatory system. So this circulatory system is a major concern for us in pharmacology, because if you cannot get to the circulatory system, you cannot get to the tissue. The circulatory system is the subway. The circulatory system is what's gonna take you to the tissue. So remember the problem with vitamin D and calcium. Somebody drink the milk, a gallon of milk every day, but they have vitamin D deficiency. You can drink all the milk in the world, but if your vitamin D is low, because in industrial societies we live in the office and there's no sunlight and there's not enough vitamin D, so the milk goes out where it entered. It doesn't get absorbed. So you have a deficiency in calcium even though your intestines are full of calcium because they couldn't get it in. You have money in the bank, you can withdraw it. What's the difference having no money? It's there in the bank, you can withdraw it. Same thing, you drink the milk, it's rich in calcium, but you cannot absorb it from the intestine into the circulatory system. So that's a major concern. So we have to look at how does the medication make its way to the intestine for absorption. Then does it successfully arrive to the circulatory system? Then is the circulatory system able to deliver the medication to the tissues? Now we are successful. Then are the microsomal liver P453 enzymes able to metabolize the drug, converting it from non-polar into a polar substance for excretion? And now we have successfully did the whole operation. Entered a xenobiotic. The medication is a xenobiotic. It's not a part of your body, but we have to host it, accommodate it, allow it to enter into the body, perform its function, and escort it out. Do its job and go home. Otherwise, if it builds up, it's going to do what the philosopher 1,000 years ago said, it's going to turn into a toxin. So we always concerned with both the medication and the toxin. How are they going to enter into the body? How are they going to be absorbed? How are they going to reach the blood circulatory system? And after they reach the circulatory system, how are they going to reach the tissue? And once they reach the tissue, they're going to do their job, and then we're going to begin quickly the liver microsomal P450 enzymes to metabolize this medication, converting it from non-polar into polar so it can be secreted in the fecal matter and primarily in the urine. So that's a major concern for us. So we have our routes of entry, the skin. After the skin, absorbed into the blood vessels that are underlying the skin. We have the connective tissue. So right below the connective tissue, we have a lot of conduit. You have a subway of the blood vessels. So that's how the xenobiotic, and the topical cream, that's a medication. So the poison enters through the skin, the medication enters through the skin and leaking through the dermis and the epidermis and the hypodermis, and then jumping into the subway of the blood vessels and making it into the circulatory system. And now you know it made it to the tissue. You get to the circulatory system, you're in the subway, you're now circulating the body. So that's as far as topical creams or xenobiotics or toxins that are entering through the integument. So when we say xenobiotic, it's a foreigner substance that makes its way into the body. So a drug is a xenobiotic and a poison is a xenobiotic. A drug who doesn't get metabolized is gonna become a toxic. So we're looking at the one route. We said the integument. The second route is the respiratory, the nasal cavity, the oral cavity. You know, this industrial society that you're going around and the gas engine and the asbestos and the construction, and you're walking by and you're not even feeling it, and all of this toxic material is going inside your nose and inside your oral cavity to the lungs. And you know the lungs, they are able to perform gas exchange with the circulatory system. You know, you have the pulmonary circulation. Don't forget that one. Now that's some leakage route there. The asbestos, quick, it makes it to your blood because it enters through the nasal cavity and the oral cavity, the lungs, and then it went into the blood circulation. Very dangerous route. The skin is a route, the respiratory system is a route, and the last route is the GI, the gastro. You eat something. You ate some fish that is contaminated, or you ate some, or you took in some medication or some drug. That's gonna enter from the oral cavity into the esophagus, then into the stomach. Then, you know, the stomach is full of acid, so it's gonna degrade a lot of that that substance, but still some of it is gonna make it through. So it's gonna enter into your intestine. Then from the intestine, it's gonna get absorbed into the circulatory system. So we are so concerned with how do we get to the circulatory system. Circulatory system. Because you know, once you get to the circulatory system, once you get to the circulatory system, you have one ultimate destination, and that is the tissue compartment. That is the tissue compartment. And we said we have three routes. The first route is the integument, or the skin, and you have the topical creams, and you have all these xenobiotics that leak from the dermis to the epidermis to the hypodermis, the dermis, epidermis, dermis, epidermis, hypodermis, then the connective tissue rich in blood vessels, and then you make it into the circulatory system. So that's the first route. We go from the integument, which is the dermis, the epidermis, the hypodermis, the connective, the underlying connective tissue full of the blood vessels that are going to bring us into the, yeah, you can have a seat. That are going to bring us into the blood circulation.
Appreciate it.
Yeah, no problem. Okay. Can I just leave this here, please? I forgot to bring my camera holder. Okay. So that's the first route.
Excuse me.
Yes.
What's the last thing you're going under hypodermis?
Under hypodermis is the underlying connective tissue. Under the hypodermis is the underlying connective tissue full of the blood vessel. You know, you guys should tell me that. You know, this is basic anatomy and physiology. You guys went through the structure of the skin. Remember, you have on the top, you have the dermis, then the epidermis, then the hypodermis, the subcutaneous fat, then the underlying connective tissue, the subway, and that's how they leak into the subway. Then we said the second route, besides the integumentary and the skin, what's the second route? Excellent. So the respiratory system, where we hijack the respiratory system, we have the nasal cavity, and we have the oral cavity, the nasal cavity and the oral cavity, and then we enter into the lungs. And from the lungs we make it to the circulatory system. You see how we were able to hijack now besides the integument? So that's how they have the inhaler. You take the inhaler, all of the aerosol, where is it going? It's going into the lungs. Then from the lungs, you have the pulmonary circulation and the urinary circulation. Now we're all going into the tissue compartment. What's the last route we are so concerned with? The GI, where you have your oral cavity and the nasal. Don't forget that one. You know the intubation tube? People think you only eat with your mouth. Yeah, when you're young. When you have the dementia and you're really old, I hope I'm not that old, but when you get old, then you have regions in your brain that are no longer, they underwent so much stress that they underwent necrosis, okay? Acute inflammation, cell death, chronic inflammation. So now they're no longer working. You know, this brain, back in the day, they wanted to see how it works. So they got a volunteer, and they knew one thing. They knew that the brain utilized, what's the number one fuel, energy source for the brain is the glucose. The brain is so reliant on glucose, it doesn't even have channels. Glucose just leak in there. It just walks inside the neuron. So it doesn't even need channels. And during times of stress and poverty, all the bodily systems give precedence in glucose metabolism to the brain. So they don't utilize glucose. They break down the muscle for protein, and they leave glucose for the brain. Like when there's famine, they give precedence to the babies and the elderly and the women, and supposedly the men, they give precedence. The young men, they give precedence to the children and to the elderly and to the women. In your body, the same thing. When there's a state of famine, everybody holds back and allows all the glucose to go to the brain. So when they knew that piece of information, they came up with an excellent experiment. They added a radioactive substance to glucose. So now when glucose is looked at, excellent. So now when glucose is looked at in the computer, it will shine. So they gave the volunteer a helmet, said to the volunteer, eat something, or showed them a picture of a food to stimulate. Then they saw a certain region in the brain light up. What does that mean? That means that this region is burning glucose. So that means it's working. It started working when it has something to do with food. So that means this is the region that regulates appetite. This is the region that regulates the processing of the food. Then they said to the subject, please start walking on the treadmill. When they started walking on the treadmill, another separate region light up, indicating that glucose is being utilized. So that region is responsible for regulating coordinated movement. Then they said to the volunteer to look at some sexually seducing imaging or videos, and the subject was sexually aroused, and then a different region lit up. So now they knew that this is the region in the brain responsible for regulating reproduction. So that's how they were able to track which parts of the brain regulate what, using glucose that is radioactive. So the more glucose that is being utilized in a particular region reflect that that region is responsible for this particular function. So we will see that many medications, and we will see that many xenobiotics and some antibiotics and some bodily substance like bilirubin, it must be metabolized, converted from nonpolar to polar quick. But when something is wrong with this enzyme, it's gonna build up in the brain now, causing kernicterus, causing some disease for the newly born who does not have these metabolizing enzymes. So now we cannot metabolize this substance and excrete it in the urine and get it out. It's going to travel with the circulatory system to the brain and it's going to build up there. So we are always concerned with how to enter, process, integrate, control the medication, and excrete this medication. We're also going to be examining in pharmacology how to ensure we always have a state of U. We don't have a hyper, we don't have a hypo condition. So we are so concerned that, you know, in our body is equipped with built-in systems. So we exist pharmacologically, we exist in a state of homeostasis. One student once, I said, what is homeostasis? And one student said, balance. That cannot be any more wrong. Because the balance means equal. So now if you are in the North Pole, you're in the North Pole, it's 0 degrees over there, equal means your body has to be 0 degrees also. And then you're dead. The dead body is in balance with the external environment. So if you really want to understand what homeostasis is, you have to believe in one thing very important. That there's also always two environments. There's an external environment and there's an internal environment. So you have to see that we have an external environment. That is the environment from which we're trying to get the medication into our internal environment. Now these two environments, the external environment is much bigger than the internal environment. But the internal environment is equipped with built-in homeostatic systems to help it fight the external environment. So the external environment always applies stress. There is physical stress. What is physical stress? Physical stress always comes in two forms: hyper, hypo. Hyper something, hypo something. Hyperthermia, hypothermia. Hyperglycemia, hypoglycemia. Hypercalcemia, hypocalcemia. Hyperphosphatemia, hypophosphatemia. Hypertension, hypotension. So we're always dealing, people is the more the better. The more glucose the better. The more calcium the better. Till you get calcium salt stone and kidney stone. Okay, so it's not always the more the better or the little the better. Oxygen, we love oxygen. The more oxygen the better. Hyperoxemia, and then you die. So you have to be regulating how we balance all these supportive, lively, sustaining factors. But too much of them, like our friend from thousands of years ago, Paracelsus, the Greek philosopher, said, too much or too little, that's the dose, that is what's going to become a toxic and a stress and a poison. So the external environment is always, every single second, giving you hyper stress or hypo stress, hyper stress or hypo stress. So we study these stresses because in our medications we're always trying to counter some form of a stress. So you must have an excellent understanding of what is stress, because stress is the spark that is gonna, disease is the fire. You know the fire in the California? You know, that one did not start like a volcano. It started with a spark. Same thing, the disease starts with a little stress. And then you have inflammation. You know that's why they call it inflammation. Because it begins with a stress. I wish they called it a spark. So now it makes perfect sense. Spark, inflammation. But that's what it is. Stress, inflammation. This concept of stress, you have to master it so you can see how these pharmacological agents are able to restore health, restore homeostasis. So the concept of stress begins with this. Now there's an entire important field of, it's called stress science, where they realize that, you know, even moderate stress is good. You know, this exercise is good. Exercise is stress. Exercise, weightlifting, and cardio, that is also a moderate stress, is actually helpful for a healthy state of mind, and it has very good positive promoting effects. But too much stress and too little stress, and you're just hanging out, no stress. You're just waking up every day, got nothing to do. Let me walk around the block, see what's happening up there. And that stress, I promise you, too little stress is not any different from too much stress. But now too much, burnout. Now that is hyper stress, hypo stress. But we have to believe that we do need some moderate stress for our growth and development, for our intellectual development of critical skill and analysis. We need that. You have to believe in that. If you don't, you're not gonna work properly. Thank you again. Okay, so stress began as a coincidence. And we're gonna see this is how penicillin was discovered. Alexander Fleming, in his laboratory, he forgot a petri dish with, right next to it there was fungus, and he had the staphylococcus bacteria. So I think a piece of rotten bread fell into that petri dish. He came back the next time, he saw that the bacteria was all dead. He couldn't believe it. Somebody killed bacteria, bread killed bacteria. So they realized it wasn't the bread, it was the fungus. That is the rotten. You know, have you ever seen rotten bad bread? It becomes like green spots. Oh, that one is good. When you were injured, back in the day, they used to bring rotten bread, put it on the pus. Yeah, because now the antibiotic from the fungus is gonna go into your wound. It's gonna heal the wound. Yeah, it used to be like that back in the day. Actually, about not even that long ago, 1950. There's videos of nurses teaching, you know, nurses learning about how to apply rotten, molded bread to a wound that is infected, bacteria with a parasite or a worm or some other form of fungus, and then after a while it heals. So it wasn't the bread, it was the fungus because you know they fight. The fungus we have you know, bacteria flora in our body, and these flora, they compete with any other bacteria. Make sure that we are the ones to live inside the body of this human beings. So they fight on our behalf. They fight any other invading bacteria. So the same thing, the molded bread. When it sees bacteria, it's going to secrete an antibiotic to kill the bacteria, so nobody else can live in that environment. So we use the antibiotics secreted by the molded bacteria, by the molded bread, the fungi. So now the fungus killing the bacteria. The fungus killing the fungus antibody killing the bacteria.
The same as mold? The fungus is the same as mold?
Yeah, it's a form of mold. It's a different species, but the same idea. It secretes antibiotics. So we have to see now what stress, the concept of stress. What happened was the father of stress by the name of Cellier. So Cellier is a Canadian scientist. What he did was he brought a group of rats. He brought a group of rats. Supposedly this is a rat. So he brought a group of rats, many different types of rats. And it's very important for us to see that we have different types of rats, because what he did was he injected all the rats with severe doses. What does that sound like? Severe doses. That's an example, severe dose of a hormone. So now he injected one with insulin, crazy amount of insulin, crazy amount of estrogen, crazy amount of thyroid hormone. They're all hormones, but he did too much of it. So what did the philosopher from thousands of years ago said? If you have too much of something, toxic. So now he applied stress. So when he applied these, but these are different stressors. Insulin is nothing like estrogen, is nothing like thyroid hormone. Some rats he heat up, he put them in a hot chamber. Other ones he put them in a really cold chamber. So that's a different type of stress. High temperature, low, not dying, but they were suffering. So that's how they did the experimentation. Then he took out all these rats, the ones who got different injections, the ones that got different high temperature, too low temperature. When he examined them, he realized there's one thing in all of them the same, even though they've been through different stress. One got too much estrogen, one got too much thyroid, one got too much insulin, one got too much temperature, one got too little temperature. They had the same thing, stress ulcer. All their ulcer, all had ulcers. So that's now they realize, as a nurse, when the patient comes in and you see they have an ulcer and they do the endoscopy, they think, oh, it's H. pylori infection. No. It could be maybe the bacteria, the H. pylori, is secreting a toxin, the endotoxin, to injure the different layers of your stomach. So this H. pylori is chopping up different parts of your stomach until it bores right out. That is a potential cause. But then they do the H. pylori breath test, and the patient blows air. Then they do the urea breath test, and they got no H. pylori, but they still have an ulcer. Oh, now that patient may be suffering from anxiety, depression, some sort of stress. That's known as a stress ulcer. So this stress is the beginning of the road to developing disease. No disease happens without stress. And we said we classify stress differently. We talked about physical stress. What's an example of physical stress? That is the temperature, the thermia. And we said we have two types of stress: hyperstress and hypostress. Hyperthermia, hypothermia. That's physical stress. Too cold, plus. Hyper, up, going up, hyper. Hypo, going down, hypo, minus. So an increase in the temperature or a decrease in the temperature, both of them stress. Hyperthermia, hypothermia. Hyper stress, hypo stress. We don't want hyper. We don't want hypo. We want euthermia. EU. We want euthermia. We don't want hypercalcemia. We don't want hypocalcemia. We want eucalcemia. We don't want hyperphosphatemia, hypophosphatemia. We want euphosphatemia. We don't want hypertension. We don't want hypotension. We want eutension. So our medication, these pharmacological agents, are always trying to help restore some hyper stress or some hypo stress into U state, depending on the system. Let's say hypertensive medications and hypotensive medications. Hypertensive, that's a hyper stress, high blood pressure, high contractility, high cardiac output. So we're going to bring that down to eutension. Hypotension, too little contractility. The electricity is not allowing the muscle to contract as much. So we want to repair that from hypotension into eutension. So we're going to study how these pharmacological interventions are going to restore some hyper into hypo. So our first type of stress is a physical agent. Then we're going to look into how these topical creams can help with the ultraviolet radiation. Now that is some serious physical agent. That is a carcinogen. And we're going to see how the hyperthermia and the hypothermia are going to be restored with pharmacological intervention back to state of homeostasis. Then we're going to look into chemical stress. Chemical stress, what is chemical stress? Chemical stress is some corrosive, chemical stress is some corrosive and some abrasive chemical agent, like a detergent, spilling the detergent. You know, sometimes you have people drinking the ethylene glycol, the antifreeze. That's an example of a chemical stress. Yeah. And so that's physical stress, chemical stress. What's the other type of stress? Infectious microbes. Is that not a stress? Infectious microbes. That entails bacteria, viruses, parasites. Bacteria, viruses, parasites, worms, fungi. These athlete's foot, that's an example of a fungal infection with ulceration between the toes, white plaques. So that's an example of a microbial stress. So whenever there is stress in the external environment, the internal environment is going to fight back. It's going to fight back. The internal environment is going to fight back. It's going to fight back with adaptive mechanisms to overcome this stress. What are the adaptive mechanisms? The adaptive mechanisms are depending on the stress. But these adaptive mechanisms, they have a limit. When it's too much, then it's too much. If the stress onset was so rapid versus slow. Oh, we don't want rapid. Rapid is dangerous. If the onset of the stress was so lightning bolt, lightning stress, lightning offensive microbial attack, lightning fast chemical stress. So the onset is the number one concern we have. What's the second concern? The duration. How long is this stress happening? I mean, the temperature cannot be that hot. Or maybe the outside right now is cold, is manageable. But if you're standing there for 3 hours for a duration long, so then that's going to become a pathology. So the duration is a very important factor we worry about. The duration of the disease. For how long? You have a flu for 1 day. You have a flu lingering for 2, 3, 4 days because you don't want to go to the urgent care. Because you don't want to take the necessary steps. So the duration takes, then that's going to cause, as you will see, the development of the pathology. So the duration is short. We love short. We hate long. The onset, we love slow, gradual. We don't want rapid. And what's the last thing? The intensity is how severe the stress is. I mean, outside it could be 15 degrees. That's intense. But think it's like the North Pole. Now that's really, really cold. So now the intensity, maybe the onset was not that fast, the duration was not that long, but the intensity is so cold. Now that's a very big dangerous factor. What about the intensity of the heat? It's hot outside, we're sweating, it's about 30 degrees Celsius. That's hot. Now imagine it's 500 degrees Celsius. Now that intense, really intense. So we're always concerned about the intensity of the microbial attack. This still, the patient is coughing. Now that's a really intense stress. So the intensity is severe versus light. We love light and we hate severe. So now our built-in mechanisms are going to be overwhelmed if these guys come in. If the onset was rapid, if the duration was lingering on, long duration, and if the intensity was severe, then your body will say, oh, that's too much. That is more than my capability. That is more than my capacity. But for the most time, your body wins. That's why we are alive. Your body wins because the homeostatic built-in survival systems, they reverse the stress. They reverse the physical stress. They reverse the chemical stress. They reverse the infectious stress. They reverse the trauma. They reverse the uncontrollable cell division, the cancer. But if we are going to study pharmacology, we're going to assume the latter, the unfortunate, that your body did it, so we can see how the medication can help. Then we move on. When the damage happens, when stress wins, you go heading into disease. When your bodily built-in mechanisms win, you're restoring health and homeostasis. But we're not talking about health and homeostasis. We're not in physiology. We're in pharmacology. So we're going to go in a dark crowd now. So now we're going to assume that the stress is overwhelming. The onset was rapid. It was not slow. And the duration was long. It was not short. And the intensity was severe. It was not light. Then the next step is the cellular death. The cell has to die. The cell is damaged beyond salvage. Damage beyond salvage. So damage beyond salvage is damage beyond repair. The cell cannot be repaired. So now the cell has this special programmed cell death. The cell will say goodbye. So all of you guys, let's assume you are a tissue. The tissue is made up of multiple cells, but the cells, they don't sit like you guys, separated from one another. They are so, in fact, they have CAMs, cell adhesion molecules, CAMs, cell adhesion molecules, like staple. The cells are stapled with each other. And you will see that some of the diseases, like Duchenne muscular dystrophy, something wrong with these staples, something wrong with these junctions, they fall apart, then that's a disease known as Duchenne muscular dystrophy, and we're going to look over the medications that we're going to take for that. But in the end, yes?
Can you repeat CAM again?
Okay, CAM is cell adhesion molecules. They make the cells stick together as one tissue because the cells are not separate. They stuck together. Cell adhesion molecules. Very good question. So now when there's damage beyond salvage, these cell adhesion molecules that are bringing the cells together, the cell will say, I'm so close to everybody. If I die, if the cell membrane fracture, if the cell membrane is like a nuclear plant. Imagine there is a nuclear plant spill. What's going to happen to the neighborhood? All going to be destroyed. The cell has lysosomal enzymes, proteolytic enzymes, metalloproteinases. These enzymes, if it break out, is going to destroy the nearby tissue. So, God forbid, this is just a random example. If you guys are sticking together and somebody's they're injured and they start bleeding and the blood spills over everybody else. So that's an example of what happens in necrosis. When the damage is, the onset was rapid and the duration was long and the intensity was severe, the cell dies by necrosis. It bursts open and all the inside lysosomal degradative proteolytic enzymes, metalloproteinases, the reactive oxidative species, and the acid is going to spill all over the tissue, destroying the tissue. We don't want that. We want apoptosis. Apoptosis. So apoptosis is programmed cell death. So when the cell dies, or programmed cell suicide. So when the cell dies in a healthy way, the cell starts to break apart into harmless blebs. Harmless blebs. Harmless blebs. The cell is looking like that, so the cell is going to say, let me burst into blebs, into circles, so this big cell is going to divide into little bags, little balloons, little blebs, B-L-E-B-S, harmless edible blebs, harmless edible blebs. Harmless edible blebs. Harmless edible blebs. Edible by who? By your own body. Eat them up. Absorb them. Excrete them. Getting rid of them. Metabolizing them and getting rid of them. Harmless edible blebs. Balloons. Vesicles. But this is not going to happen unless it's apoptosis. So apoptosis is costly. It needs oxygen. It needs energy. It needs the mitochondria. But necrosis, if the disease, that's why infarction and that's why heart attack is an example of necrosis or apoptosis. That's necrosis because there's no oxygen. If there's no oxygen, we cannot initiate apoptosis because apoptosis is initiated by the mitochondria. And the mitochondria is where oxidative phosphorylation, aerobic respiration, oxygen happens. But there is no oxygen. So there will be no apoptosis. Now there's necrosis. That's the dangerous one we don't want. So now we're going to move from cell death to necrosis. If it was apoptosis, that's just what we love. We want. So just because the cell is dying, that's not the problem. As long as it's dying with apoptosis. If the cell is dying with apoptosis, then we love that. Because it's going to get rid of itself properly, dispose of itself properly, and is a harmless, edible blebs. Then the tissue is going to heal with regeneration, and you're going to have a new cell. We're going to go into the cell division cycle and burst more cells in its place. That's if apoptosis. But if it's necrosis, oh no, there's no time for all of that. No time to initiate apoptosis, no time for oxidative phosphorylation, no time for aerobic respiration. The cell just burst out, and the nuclear membrane, the plasma membrane, is fragmented. So all the nuclear dangerous proteolytic enzymes, the acid, the reactive oxidative species, the degradative enzymes, everything burst out, destroying the nearby tissue. So we are aware of what's apoptosis. So medications, pharmacological interventions help facilitate apoptosis. But we're going to go, remember, we're always going in a dark route. We're going into the things going wrong, not things going right. But we're going to the things going wrong. So now we're going to move on to necrosis. So now you have to have a mental picture of what necrosis look like. Oh, it's ugly. Oh, necrosis is bad and dirty, and you have the cell membrane This is the first thing, the first mental picture you have. You know, they say, I'm taking my kid to the park. The first thing that comes to your mind, the slide and all that. When you see necrosis, the first thing that should come to your mind is the plasma membrane broken. All the intercellular lysosomal degradative enzymes, the metalloproteinases, the acid, the reactive oxidative species, all loose now. All the lions coming out, destroying nearby tissue. And then, if that is not remedied in time, we're going to move to the next step. What's the next step after necrosis? Acute inflammation. Acute inflammation. And acute inflammation, we don't repair that in time, we're going to move into chronic inflammation. Chronic inflammation. Chronic inflammation. Necrosis, acute inflammation, and chronic inflammation. So when there is chronic inflammation, now you know that there is so much damage, there will never be healing by regeneration. We're going to heal by fibrosis. We're going to heal by scar tissue formation. So you know when you have lung fibrosis, oh, you need new lung now. You need lung transplant. You never go back from that one. Because when you reach chronic inflammation, that's why smoking the cigarette, smoking the weed, and all of that stuff is now going into the lung. Stress. Oh, I'm fine, nothing, I don't feel anything bad. Now you don't. Wait till you get older. And then you have necrosis, and then you have, because you know the smoke nicotine is gonna prevent, and the cannabis from the weed is gonna stop the hemoglobin from unloading the oxygen. So oxygen is there. Remember when we said earlier, you got money in the bank, you can't withdraw it. So hemoglobin is full of oxygen. It want to give it to the tissue, but it cannot, because the nicotine from the smoke and the cannabis from the weed is gonna lock it into the what's known as the S state, the closed state. Imagine you are in an Uber, you want to come into the school, but you can't open the door. The Uber is locked between two cars, and you can't open it. You are right there, you want to come in, but you cannot get out. So now you see that's gonna drop the oxygen level, disturb oxidative phosphorylation, disturb aerobic respiration, cause necrosis, acute inflammation, chronic inflammation, then fiber tissue dumping, scar tissue. So that is what liver scarring, fibrotic liver disease, cirrhosis is severe fibrosis. So you can never have fibrosis unless you had chronic inflammation. You can never have chronic inflammation unless you had acute inflammation. You can never have acute inflammation unless you had necrosis. You can never have necrosis unless you had cell death. You can never have cell death unless you had cell injury. If you never had cell injury unless you had a stress. Oh yeah. So all start with a spark. That's why they call inflammation, flame. And you know with the inflammation, the pharmacological interventions we're gonna have, you're gonna see they're gonna target the inflammation. Inflammation is rubor. Rubor, that is redness. This is in Latin. So rubor, that is redness. Calor, that is heat. So inflamed tissue is hot. Inflamed tissue is red. Inflamed tissue is tumor, is swelling. Inflamed tissue is swelling. And inflamed tissue is dolor, pain, is painful. Inflamed tissue is painful. And functionalasa, loss of function. So the tissue that is inflamed is losing the function. It cannot do its function. So now we're going to apply medications that will stop the pain by inhibiting the cyclooxygenase pathway and now we're not gonna feel the pain, because the pain happens when there is irritation of the nerve endings in the necrotic tissue. So now we're gonna take Advil and Tylenol, and these guys will inhibit prostaglandin synthesis, and when there is no prostaglandin synthesis, there is no pain sensation, because prostaglandins mediate pain sensation. They irritate the nerve endings. So now you're gonna take this antihistamine. The antihistamine is gonna stop the heat and the redness, because in the inflammation, you're gonna have the squeezing of the blood vessels, because we have vascular spasm. We don't want to lose a lot of blood in the necrotic tissue. So now you gotta take antihistamine to relax the blood vessel. So that's another pharmacological intervention. The swelling, there's a lot of tumor. There is not uncontrollable cell, but there's swelling because there's so much water. The tissue is damaged. There is high permeability. So this high permeability, a lot of the water is infiltrating. A lot of the water is infiltrating in the area that is suffering from the inflammation. So you see, that's why always when there's inflammation, it's bumpy. There's a bump. What is that bump? Is that cancer? It's not cancer. There's too much water. The water is leaking because there's interendothelial gap, interendothelial cleft. So the region where there is necrosis, the blood vessel, the endothelial cell are going to be open like that. They are not going to be so tightly closed. They're not going to be so tightly closed. So usually, you see this dot is a nucleus. This dot is a nucleus, representing a nucleus. So what happens is, if there is damage, we need this gap here. This gap is called interendothelial gap. Interendothelial gap. Also known as interendothelial cleft. Interendothelial gap, interendothelial cleft. Why do we have it? We have it because we want to recruit the immune system cell. We want to recruit the macrophages. We want to stimulate all of the macrophages to come, and they are phagocytes. They are cell eaters. They eat up. So they're going to eat the bacteria, eat the necrotic debris. So there's a lot of necrotic debris, falling tissue that is damaged with the necrosis. So we want pharmacological interventions that facilitate for interendothelial gap formation, and we want to facilitate for the arrival, the police. The police come, the immunosurveillance to come and remove the destroyed plasma membrane and the damaged tissue. So now this is called the classical pathway, to remove all of the necrotic debris, to fight all of the opportunistic microbial infection, so that we can initiate, after the classical pathway, the alternative pathway of the healing. So we have to have pharmacological interventions to do both. The classical pathway, removal of necrotic debris, and boosting the immune system to help immune surveillance. And then we shift after that is done, after the priority is done. First is the classical pathway, then we shift into the alternative pathway of the healing. So now we have medications that are going. So this is how the tumor happens, because through the interendothelial gap, not only the immune cells arrive, water leak also, because this is inside the body you have intracellular bodily fluid compartment and extracellular bodily fluid compartment. So when the interendothelial gaps open, the water is not going to say, well, I'm not supposed to go in there. That was open for the immune cells to arrive. That was open only for the classical pathway. Water is going to leak with osmosis from an area of a high water concentration to an area of a low water concentration. From an area of a low solute concentration to an area of a high solute concentration. That's why I see bump of water. But then it's going to go away after the healing takes place. So we're going to see the medications that are going to allow us to stop the tumor and inflammation So inflammation is a 5 system: heat, pain, redness, swelling, and loss of function. So you take different medications to target each of the 5. So we don't just give a medication for pain, analgesic. We don't just give a pharmacological intervention for the swelling, the edema. We don't just give pharmacological intervention for the redness, antihistamine, all this blood rushing to the site of the inflammation. We want to stop that. Stop that rush of the blood. So this is now the inflammatory. So the last thing now is for us to prepare ourselves that all of the pharmacological interventions that we are going to analyze, they're gonna target one of 3 diseases classifications. So if there is a disease out there, it's either one of 3. It's either what we just talked about, the inflammatory. It's either an inflammatory disease. It is either an inflammatory disease, inflammatory, so we're going to be dealing with redness, rubor. We're going to be dealing with pain, dolor. We're going to be dealing with heat, Kaler. We're going to be dealing with swelling, tumor. And we're going to be dealing with loss of function. And that is functional laser. That's inflammatory disease. But is this the only pharmacological intervention we're going to have? So we only have medications for inflammatory diseases. We only have medications in the pharmacy. There is nothing, no medication except inflammatory disease medications. Is that true or false? Of course false. There are 2 other families. There are 2 other families of pharmacological interventions classified based on the disease. So inflammatory, that's number 1. What could be the second family of pharmacological interventions based on the disease we're going to target? So besides having the inflammatory diseases, what are we going to have? Yes? So viral, remember, viral is an example: viral, bacterial, fungal, parasitic infection. That's going to lead to necrosis. Necrosis is the spilling of these degradative lysosomal enzymes. Then inflammation. So that leads exactly. So trauma. If does the viral? You mentioned viral or bacterial? Viral. Okay. So does the viral infection have anything to do with redness? Does it cause redness? Does it cause heat? Does it cause pain? Does it cause swelling? Then that's inflammatory. So we need another family that has nothing to do with those. You're still sick, but no redness, no pain, no swelling, no heat, no loss of function. What could that? Respiratory? So we have respiratory inflammation. So respiratory is the system. So the respiratory system can be harmed inflammatory. It can be harmed also in 2 other ways. So everybody can get inflamed. Your cardiovascular system can get inflammation. Your skin, your integumentary system can get inflammation. Your endocrine system can get inflammation. Your urinary system can get inflammation. Respiratory system can get inflammation. What else can they get that is not inflammation, not redness, not pain, not heat, not swelling? Yes? Okay, so chronic is a classification based on the duration. So if the inflammation was so long, remember in our chain, you see, we had necrosis, acute inflammation, then chronic inflammation. It's a stepwise, so that if the inflammation happened for a month, then that makes it up to 3 months, that's acute inflammation. Up to more than 3 months, that is chronic inflammation. So chronic and acute, that is inflammation. So we need something that has nothing to do with inflammation. Yes. Genetic. You're very close, because genetic diseases can also lead to inflammation. So you can have a genetic disease that makes me susceptible to developing infection, but you are so close. You're heading in the right direction. So genetic is inheritance. So we have two aspects. There is genetic, nature versus nurture. So there is us and there is the surrounding. Genetics is nature, us. Nurture is what comes from the external environment. So what it is close to it, really close to it. Genetic, yes.
Is it genetic?
Behavioral disease. Okay, so the behavioral disease can happen due to mad cow disease. So mad cow disease or these psychiatric diseases can happen because of inflammation of the brain. So you're right, that is, behavioral disease is a sign, a symptom of a disease, but we're looking at the underlying causes of the disease. So an inflammatory disease can reflect in behavior. Sometimes you can be so agitated because you're sick, because you had the inflammatory disease. What other disease you could have that is not inflammatory? Maybe later, these disease families, they can change. You can have some disease that later become inflammatory.
But they could have pain, Prof. They could have pain, right?
Yeah, they could. No, once you're in pain, you're in inflammation. But it can later develop pain. It can later become inflammatory. It can shift. It can shift from this to that. And they can shift from this to that. And you can shift from this to that. And you can shift from this to that.
What a viral disease?
So viral, we said, is microbial. Viral, like your friend. She said viral, microbial, parasitic, bacterial. They always call that. Yes. Mental. So she mentioned behavioral. So mental disease, why is it like that, the mental disease? So for example, we can classify a stroke as an example of a mental disease, because we said the radioactive glucose shine in different regions, so different regions target different things. If you got a stroke, a certain region is destroyed beyond repair. That means if that region is destroyed, you cannot do that function. You cannot walk. Somebody with a stroke cannot walk. Somebody with a stroke can walk fine, but they cannot talk because yes. So a stroke is an example of inflammatory because there is necrosis. So mental is not an underlying cause. Mental can develop based on inflammatory. So you can have inflammation that lead to mental. You can have one of these guys, number 2, lead to mental, and number 3 leads to mental. So mental is not one of them. Yes? Yeah, congenital. Excellent. So you have, this is what your friend was saying, genetics. So you can have congenital diseases. So congenital disease, excellent. Very good job. Congenital disease, there's no inflammation here. You are born with some embryological defect. You not even having no bacterial infection, you're not suffering from any sort of hyperthermia or stress. You are born with a structural or physiological defect. So structural, anatomical, defect. Structural, anatomical defect, or physiological defect. So for example, a baby is born running on the mommy thyroid hormone, which is important for intellectual development. If the thyroid hormone of the baby is not there, if the thyroid is late in development, that baby needs exogenous thyroid hormone quick. Otherwise, they will have mental retardation. So that shows you there is a physiological congenital defect, inability to, in the embryological the development, to develop the thyroid gland. So now the thyroid gland cannot make thyroid, and now the baby cannot develop intellectually. Was that inflammation?
No.
That had nothing with redness or pain, or the baby he wasn't even in pain. There's no swelling. It's just the thyroid is not working, or there's a defect, a neural tube defect, spina bifida. Was that an inflammatory? That's just congenital. You are born with. Remember the definition for congenital disease is anatomical, structural defect, something wrong with the structure. Like we mentioned, Duchenne muscular dystrophy. There is a problem with the staples that hook the cells together in the connective tissue, or physiological. The structure is fine, but the job cannot be done. So that's the second family. We're going to be looking at, in addition to inflammatory disease, we're going to be looking at congenital disease medications. How we can apply some medications to help repair and speed up the development and growth of a malaligned or malformed congenital defect. And if this is not happening, it can now shift to inflammation. Later on, the congenital disease can become inflammation. Or maybe after the baby is born, you don't only develop in the mommy uterine. When you're born, some inflammation causes embryology, causes congenital disease. So while the baby is growing up, they get some sort of infection, microbial infection, or some sort of trauma, road traffic accident. It prevents their development, so they acquire a congenital disease, even though they were born congenitally fit. Yes?
So, a child can get something like that from the mother's milk or drinking?
Of course. Yeah, these are called teratogens. There is this medication known as thalidomide. This was in the 1950s. Thalidomide. This thalidomide was given to pregnant mothers that led to the destruction and the damage of the embryo. So yes, so the mother, because remember, alcohol is a stress reactive oxide. So alcohol, when alcohol is entered, it gets metabolized to acetaldehyde. That's the reactive oxidative species, ROS, reactive oxidative species. So the reactive oxidative species, these are free radicals. Free radicals. These free radicals are very important, are used by your immune cells to kill the bacteria. These are one of the weapons. You know, the police has a taser, it has a gun. So the reactive oxidative species, these negative charge electrolytes, are used by your own immune system to destroy and damage the bacteria. But now it is damaging your own body because the alcohol gets metabolized into reactive oxidative species. So this alcohol and the nicotine drop in the oxygen, and all of that gets transferred through the placenta to the baby, and then the baby is going to have a congenital disease. In both, you can have it concurrently. You can have inflammatory and congenital. Very good job. One more. The last one. You forgot. You don't see one empty in the middle? One more. You see one over here? Yes.
Like it turns to antibodies or antibodies.
So can you say it again?
No. Second one, it's like it turns to antigen or antibody.
So antigen antibody, like rheumatoid arthritis. Is there pain in rheumatoid arthritis? So that's inflammation. So when your own body got amnesia. So now what is autoimmune? Autoimmune disease. So auto meaning self. Autoimmune. Remember earlier we said xeno. So xenograft. There is xenograft. And there is autograft. And there is allograft for graft rejection. Allograft is when they take from autograft, is when they take from your body to patch somewhere else. You have an injury, you have a burn, 3rd, 4th degree burn, the plastic surgeon take some from your buttocks skin and patch it to your burned region, it'll be fine. But that's from you to you, you to you. But if it's from somebody else within your species, from a monkey to a monkey, from a pig to pig, from human to human, that is allograft. But if it's from a pig heart to the human being, that's xeno, that's foreigner. Your own body is not foreigner. Your friend, your own species, that's not foreigner. But another animal to you, the baboon heart, that is xenograft. So now, these antibodies, your immune system gets amnesia, so it doesn't know self from non-self. Like the police or the army. The army is supposed to fight another country. Now the army come killing people in the US. It doesn't remember that this is my own people. I need to go fight another country. So the same thing, your immune system is going to mistakenly assume that your cartilage of the knee is some virus, is going to hypersensitivity. You take some pollen in your nose or pet dander, the pet, you hug the dog, it goes inside your nose, your immune system is going to think that, oh, this is some sort of dangerous microbial agent. It's going to mount a severe inflammatory attack, but it's really nothing. So that's an example of an inflammatory disease. Inflammatory disease is when there is amnesia, the immune system. You know how the immune system works? It recognizes the glycocalyx. The glycocalyx. So the glycocalyx is a set of proteins and sugars on the surface of your bodily cells. Your glycocalyx is different from my glycocalyx. The only two who have glycocalyx are who? The same glycocalyx are who? Mom and a baby? No. Identical twins? Yes.
I'm in this class.
You're in this class? Okay. Is there a seat? Okay. Is there a seat? There really no seat? Oh, there's one over there. Okay, there's one over there. Thank you. So the glycocalyx. What is the glycocalyx? On the surface, this is really important. So we're gonna see some pharmacological interventions that are gonna help your immune system recognize the glycocalyx and sensitize and desensitize. Sensitize meaning you're hypersensitive. We're gonna desensitize, calm your immune system down. So what's the glycocalyx? The glycocalyx is the glycocalyx. The glycocalyx, let's see, this is the surface of the cell. There is proteins, lipids, sugars, carbohydrates, but they have a different set. You have protein. Protein is like a phone number, 718-234-5678. So the set of mixture of proteins, lipids, carbohydrates is the glycocalyx. So your glycocalyx is different than my glycocalyx. That's why if you give me blood, it will be rejected. You give me a kidney, I give you a liver, they will be rejected because our glycocalyx is different. Who are the only two ever to have the same identical glycocalyx? Excellent. I said the keyword. Identical twins. You know you can have fraternal. You can have fraternal twins. You know, I trick my students. I say, which of the following have the same glycocalyx? A mother and her baby, a father and his son. Fraternal twins, identical twins. They say a mother and her baby. It's the identical twins. They can give each other anything. They can give each other a liver. They can give because they have the same glycocalyx. So we're going to look at pharmacological interventions that help your immune system realize, hey, that's your own glycocalyx. It's not a different one. We still at the same problem. Who is number two then? Number two. So you guys giving me answers. We're going to see if we can relate them to one, but we already established the key concept that they can switch. We can go from inflammatory to congenital or from congenital to inflammatory. They can switch. Who's in the middle? I cannot believe you could not see. Think about it. What kind of diseases we did not mention here? In terms of onset, so that what's going to make you find the answer is how the disease gets the onset. It starts as inflammatory or starts as congenital. What can it start as? Don't think about later. Later is going to be inflammatory. It could be congenital. But from the beginning, what could it be? What's missing here? One of it. Think about it. She already got extra credit. I want one person to get it to get another extra credit. What is missing from here? I'm not going to. Or I can tell you what to start with. Yes.
Can be triggering? Triggering?
Triggering?
Yeah.
What do you mean triggering?
I mean, starting.
Starting. No, I'm gonna take away your extra card. No. It's not triggering. What do you mean triggering? They're all triggering. The three of them, inflammatory is triggered. Is by some form of stress. Another stress causes congenital. What is the missing one? Genetic, like your friend who's in front of you. She said genetic. She was close to saying congenital. But some genetics lead to inflammatory. Not all genetic problems lead to defects in the development.
So it's like a.
What kind of hospitals we have in this world? Yeah, who said the cancer? That's you? Excellent. Cancer. So we have tumors. These are benign tumors and the malignant tumors. So you have uncontrollable cell division. Excellent. So we have tumors, and these tumors are divided into two types. You have tumors that are benign. These are harmless tumors. They do not invade nearby tissue. They don't damage nearby tissue. And then you have malignant tumors. And these are the tumors that they hijack the circulatory system. You got a tumor in the lung traveling all the way to the bone through the circulatory system. But these tumors, they are caused by, not by inflammation. No inflammation causes tumor. No congenital disease causes tumor. But you have some form of a mutation or some form of a genetic defect that causes, that's why I feel you're so close with a genetic problem. Because cancer is a genetic problem, a genetic disease. Excellent job. You're going to get extra credit. Excellent job. Tumor. I thought she raised her hand.
It was me. I said cancer.
You said cancer too?
Everybody said cancer.
Everybody said cancer. Excellent. Excellent. Okay. Yeah, the two of you. Yeah, I heard the two of you. So, tumors, they are a result of uncontrollable cell division. So you have the cell cycle. You know the cell cycle is divided into two phases. The cell cycle, this is really, really important. The cell cycle is divided into two phases. The first phase is, no, meiosis is not cell division. Meiosis is for the gametes. So it's divided into two big phases. The first one is called interphase.
Telophase.
And then the second one is called mitosis. The interphase is your G1. Then you have your S phase, then G2. That's the interphase. Then you're going to begin mitosis. That is prophase, then metaphase, then prophase, then prometaphase, then metaphase, then anaphase, then telophase, then cytokinesis. There are loss of function mutations, or there are gain of function mutations in these oncogenes that cause the cell to go awry. So these cells go awry because the problem here is that we spit in the cell cycle uncontrollably. So now a tumor develops. This tumor can develop benign uncontrollable cell division, and then there is a malignant where in malignant there is invasion and metastasis. Invasion, some students have a difficulty understanding the difference between invasion and metastasis. So invasion is when you invade the basement membrane, you start infiltrating and going beyond your parameters as a cancer cell, start to destroy nearby tissue. And then metastasis is when you jump in the blood and you move away. So now not only you infiltrate the tissue, now you're swimming in the river, in the bloodstream, going to a very far place. That is metastasis. You gotta know the difference between invasion and metastasis. Yes?
So invasion would be more so like, say somebody has cancer of the lungs, it would just probably destroy that lung versus the, I'm not too sure the other word. Versus,
Metastasis.
say like you have cancer in your lungs, it goes to your kidney, and so.
You defined it perfectly.
Okay.
You write that on the exam, you get full credit.
Okay.
I don't give you full credit, you can take me to the court. That's the perfect answer.
Okay.
Every doctor will tell you that's the perfect answer. Invasion is when you infiltrate locally in the tissue that is nearby. Metastasis is when you take the transport system and you go to the bone or the kidney and the brain, and metastasis. You can't say I don't know what that other word is. You gotta know what that other word is. Invasion and metastasis. Invasion and metastasis. Very good. Oh boy, that was a lot. So now let us look at the lecture. I think we went over everything. So now let's just go over it with the slides. This is a very interesting system of technology. I'm gonna be making you guys, I'm gonna tell you about the assignments and the exam, and I'm gonna give you a study guide for your exam. So on the exam, you're not all over the place. You don't know what to focus on. You don't know like what exactly. I mean, it's good to read the book. It's gonna give you an excellent impression of the objectives we're trying to cover, what the exam is going to cover. So it's really nice to read the chapter to give you an idea, a GPS. But if you want to do well, you focus on the study guide. So you answer the questions of the study guide. You can work together on them, but you have to submit the study guide question answers uniquely on your own. And you don't submit the question, just the answer. So I'm going to give you the questions, and then you look at the questions, you discuss them together. I welcome that. You guys work together. But your answer cannot be the same. You cannot be copy-pasting the plagiarism and from online. You can copy-paste it first to see that the answer, but you must rephrase it. Because when you're going to submit it, I'm going to run it through the plagiarism checker, turn it in, and that's going to tell me green is good. Red, that's plagiarism. So you have to make sure you're going to work on it, revise it, understand it. When you come to the exam, you're going to see the question is just what was on the study guide. So if you answer the study guide questions, it's like a mirror image. I am not like trying to challenge somebody or test your IQ. I'm very straightforward. You do this all the time. Most my grades for my course is 8.
Oh.
Last semester, most of my students got 8. Unless you don't want to do work, you don't get 8. But if you're willing to show up on time and learn and participate, you see everything I try to make clear, and you see the questions are going to be just like the study guide. You see these videos here? You also are gonna refer a video for you. You're gonna sit home nicely. That's especially for the next section where they gotta come to school around 5 p.m. where the brain shut down. So they're gonna be here. I'm gonna lecture them, but I'm pretty sure everything's gonna get metabolized, it's secreted. So that's why I love these videos. So you sit home one day in the week and you wake up in the morning, you watch this video at your own pace, then you summarize it. So you summarize this video. You will see these videos are very nice. They explain to you really well. Some students tell me I like them. I start watching most of them even for other classes. Like, okay, you could do that in the summer. For now, focus on this. Okay, but these videos are not challenging at all. So you're gonna sit down and you're gonna listen to them, and then you're gonna summarize the key concept. What came out? So what jumped into you? And then you're gonna rephrase for me what I discussed. So you're not just gonna talk about a couple of things. What were the points that I discussed here? The toxicity, the CP450 enzymes, the different routes. You know, we talked about. So if you see here, this is talking about the xenobiotics. So if you see here, you see here, I have air. That is how the xenobiotics come in to the body. You have the air that's gonna go into the lungs. You see, from the air, the asbestos going into the lungs, or from the water going into the GIT, or from the skin going into the blood vessels, then to the circuit. So this here, you see the circulatory system in the heart, and then once the three of them make their way to the circulatory system, what happens? See where my mouse is? Distribution to tissues. Then when we distribute to tissues, there's toxicity and there is storage of the toxin in the bone tissue, in the lipids. You see, we talked about that. And then your liver cytochromal P453 enzymes are going to metabolize. They're going to metabolize this xenobiotic. It could be a medication, it could be a poison. In the end of the day, it's xenobiotic because it wasn't made in your body. Advil and asbestos are both xenobiotics, but one is going to help me and make its way out, but asbestos is very hard to metabolize. So then I'm going to talk about how the metabolism happens in two phases. The first phase is activation, where I perform mechanical reactions and I go from oxidation, reduction, hydrolysis. Then I convert. You see what my mouth is? From lipid soluble into a metabolized into a polar. You see polar? That you see my handwriting? God help you. You see polar xenobiotic. It used to be lipid soluble poison. Then it gets, you see the arrow pointing to polar xenobiotic. Then phase 2 is going to be, we're going to add glucuronic acid. You know the spices? You add the spices, you add the dressing. Now you're going to add the spices, the glucuronic acid, the glutathione, and then we're going to add that to the bile from the gallbladder, and then it got out. You see the yellow? Excretion. You see it went out to the excretion. You see, then we successfully metabolized everything, and then we're gonna excrete yellow, and then we got rid of the poison and the drug both alike. So these are the videos that I'm gonna attach for you, and you're gonna watch them and summarize them and upload that also. You can discuss, watch it together, discuss together, add all the points that you got from the discussion to your paper. I'm gonna read that also and upload it. Also for the plagiarism scanning, your unique copy, and then you gotta get credit for all of that. You gotta get credit for your homework, multiple choice, because that multiple choice is gonna be similar to the exam. Sometimes I recycle some questions. Some students, I put in a homework, they go, we know all about the group chats and taking a photo of the homework solution and sending it in the group chat, and then they get 100 on the homework, which is worth like 10% from the grade, then the same question on the exam and they get it wrong. So you're doing yourself a disservice. You gotta read the question and you understand the question, because the exam question is either gonna be recycled or minor rewording of the question, or the answer choice A, B, C, D. The answer was A, then I'm gonna make B, but switching around the same key concept. So you're gonna have multiple choice, you're gonna have study guide, and you're gonna have the video summaries. You do those, and you come into lecture. I'm gonna say in lecture to ensure that you come to lecture on time. I'm gonna say some stuff that I'm not gonna put there to reward you for being here, paying attention, and then you're gonna see them on the exam. And but for the study guide, I'm gonna include everything on the study guide. You're gonna do your study guide, submit it, and I look forward like working with you guys and you guys doing your best, and you learn and you develop your critical thinking. You have an excellent intuition of pharmacology, and then I give you a good grade. You have good memory of the course. You have boost your GPA, and you do well. You go on, and yeah, that's it. Yes.
Thank you.
The exam schedule. I don't even have a bright space. I was hired last night 6 p.m. This morning I woke up. I was like, let me call and say I can't come.
Oh my God.
But we are gonna work with what we have. So as soon as I get paid, as soon as I get my bright space account, when I get my bright space account and when I get my IT and all of that, I'm gonna post for you your syllabus. It's posted. Okay, so work with that because that's what I'm
The
gonna
fourth
follow.
week.
Yeah.
The fourth week is the first exam. So everything that we did.
It's like it's like in your notifications. It's like right here in your notifications. It's not like
I already have the app. Look.
Of course, everything is gonna be the key here is, guys, the key here is your announcement. You gotta you gotta read the
You gotta refresh
announcement,
it.
and when you read the announcement, you're gonna see, I'm gonna point you, tell you, this is the study guide, it's due on this day, blah, 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 this is the homework questions, they're posted, this is the video you gotta summarize, the portal is already up, upload it to the portal, blah, 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 blah. But remember, the study guide, don't put the question. I'm gonna give you the question. When you answer the question, delete the question and put your own unique answer so that it doesn't get flagged. Yes.
So you're gonna put
Yeah,
these videos on website?
Of course. I'm gonna give you the link there.
Okay.
And then you're gonna click on the video. You're gonna watch the video at home, in your car, at work.
To the syllabus, everything that he taught
But
today.
you gotta understand
It's not what we're supposed to do today.
Okay? Okay? They have an assigned book, but I'm trying to change the book to the
what is it that we have left? Do we have?
the
I mean,
yeah, I'm gonna try to use the slides of the open. They are free. You don't have to buy them. But they told me they gave you a box with books on it.
From ATI, but we didn't get it yet.
Not to buy the book. We can do it if we want to, but to follow the slides, everything on the slides, and I don't like that.
Yeah, I don't like the slides. I saw the slides. They don't make
is the
sense.
exam on ATI?
But my slide, I'm gonna show you. You see this OpenStack.com? You got anybody heard of this website before?
No.
Nobody heard of OpenStack? Wow. So you go to OpenStack.com.
Stop or stop?
Stacks. SEAX. Open. Okay, so what is happening now? I think I downloaded them earlier. Oh, there they are. That's chapter. No, I think that's the other professor. You see, that's chapter. That's chapter 1. You see? So this is chapter 1. And so this is, so you see OpenStax up here? You see where my mouse is? You see the mouse? So you go to OpenStax, everything there. the end of the chapter questions, these are gonna be, many are gonna be, as you will see, your exam questions. Let me show you. If you go to OpenStax and you go to nursing, you go to OpenStax and you go to nursing, then you click on nursing, then you go to, you don't click on clinical nursing skills, you don't click on maternal. If you want to do that for the other classes, it's up to you. You click on pharmacology for nurses. Then after you click on pharmacology for nurses, the book is right there. So you click on, this is the table of contents for the whole book. You can view it online, you can download a PDF, but if you click on table of contents, today's material was chapter 1 and 2. So drug administration, we did that drug administration, and we did the pharmacology and the science and the forms and the classification, all of that. So you can read the chapter, then you go to review questions. If you go to review questions, you see those? I promise you, I'm gonna recycle some questions in there into the exam. So you gotta do those questions, and you gotta tell what is the, so these 10 questions at the end of each chapter, you have to know them well. You have to know these questions really well for your,
Did you find your review?
okay? And that's, you look here.
Do you want me to start? Do you want me to end the recording?
Hmm?
The recording.
Yeah, we are.